Ever wondered how RAF scores impact your value-based care program? Well, you're in the right place. In this video, we'll cover the basics of the risk adjustment factor, also known as RAF, and how it's calculated. Let's dive in. In the risk adjustment model, a patient's health status is equated to a number known as a risk score. The higher the risk score, the more medically complex the patient is, resulting in a higher anticipated cost of care. The risk score allows Medicare to focus on the efficient distribution of funds to high-risk patients. The real question is, where does that number come from? In the HCC model, certain conditions will elevate a patient's risk score based on their impact on health status and higher potential for future healthcare costs. More serious conditions will alter the patient's risk score by a higher amount than less serious conditions. For example, F11.10 opioid use disorder mild will add 0.379 to the patient's risk score, but F11.20 opioid use disorder moderate will add 0.417. In order to fully understand how the process works, we need to examine what HCCs are. HCC stands for Hierarchical Condition Category, and each HCC is a bucket that diagnoses go into. The most complex portion is the H of HCC, hierarchical. Some HCCs will override or trump other HCCs. Medicare groups related HCCs with similar diagnoses of differing severity into their own hierarchy. Cancer, diabetes, COPD, substance use disorder, and psychiatric disorders are some of the diagnosis groups that have a hierarchy. As an example, all risk-adjusting cancer codes, from solid breast tumors to leukemia, are placed into one of the cancer HCCs, HCC 17 through HCC 23. Within this group, the more serious HCC will impact the patient's overall risk adjustment factor, while the others will not impact it at all. To explain how a hierarchy works, let's look at substance use disorder. This patient was coded with many forms of substance use disorder this year. These diagnoses are broken up into 3 buckets based on how serious the condition is. Within those buckets, there are multiple diagnoses. For example, in the middle bucket, you can see the patient is coded with both F11.20 opioid use disorder moderate and F14.20 cocaine use disorder moderate. These are considered to convey the same level of risk. Medicare sets the value to convey how serious a condition is and can adjust this value yearly. In this example, going from least to most serious, in the bottom bucket is F11.10 for opioid use disorder mild. In the middle bucket is F11.20 for opioid use disorder moderate. And in the top bucket is F11.251 for opioid use disorder moderate with opioid-induced psychotic disorder with hallucinations. In the second column, you can see how these diagnoses are divided into HCC groups. It doesn't matter how many diagnoses in one bucket are coded each year, Medicare just looks to see if each bucket has any diagnoses coded in it at all. The last step in figuring out the final risk score is where the hierarchy comes in. Medicare has determined that if a patient's conditions fall into a hierarchy, then only the most severe HCC will contribute to the risk score. If your patient is documented as having an opioid-induced psychotic disorder, they are at a much higher risk than when they just had opioid use disorder mild. As such, the HCC with the highest risk will trump or overwrite all the others. The diagnoses in HCC 135 will always trump the diagnoses in HCC 137, which will trump the diagnoses in HCC 138. The next factor to consider is that the risk score of a patient is tied to the patient themselves, not the clinician. Diagnoses submitted to Medicare by any clinician will add to the patient's risk profile. Each patient is required to have one PCP assigned to them when they join a managed care plan, which is a type of value-based care plan, and the PCP's organization will be reimbursed for the patient's care. In my example here, you can see patient Adam saw 2 doctors, Nelson and Kazi. Dr. Nelson coded 3 conditions in 3 different HCC buckets. only 2 of which will get reimbursed, as the code in HCC 135 will override HCC 138. Then patient Adam saw Dr. Kazi, who coded the patient with 3 codes as well. Any diagnosis in HCC 135, 137, or 138 coded by Dr. Kazi will not adjust the score, since HCC 135 was already added to this patient. But the new diagnoses in HCC 37 and 226 will add to the score. So the patient's total risk score is the sum of each risk score for a unique HCC coded for that year, regardless of who coded it. Only one healthcare organization will get reimbursed for this patient, which is determined by who the patient has assigned as their primary care physician. There are some other nuances not covered here, such as not all patients starting at the same value due to demographic information, and some HCCs have values added to the score based on coding combinations of HCCs from different hierarchies. But this should give you a quick insight into how a patient's risk adjustment factor is created. At the end of the day, understanding RAF scores isn't just about compliance, it's about delivering high-quality care. The more accurate your scores, the better the outcomes for your patients and your organization. Want to see how DoctusTech can help you track and improve accuracy? Hit the link in the description for a free demo. See you next time.